Hi class, in this lecture we will review adverse drug effects. The objectives are listed on the slide and they're also listed in your Blackboard module. These are relevant vocabulary terms. You can find the definitions in your textbook.
Reactions. So adverse drug reactions is defined by the World Health Organization as any noxious, unintended, or undesired effect that occurs at normal drug doses. These effects could be mild, all the way to severe, all the way to life-threatening. I would like you guys to review these important definitions. They're in your book in Chapter 7. I think it's on the first or second page of Chapter 7. Please review these definitions. We'll be using these terms throughout the course. Many of the drugs, they produce adverse effects, but they can also be toxic to very specific organs. And so some of the most common types of toxicities are listed on this slide. Hepatotoxicity by far is probably the most common and one of the most important. When drugs are metabolized, they may be converted to toxic products that cause injury to the actual liver cells, resulting in hepatic toxicity. In the US, drugs are the leading cause of liver failure from known hepatotoxic drugs. Just so you know, more than 50 drugs are known to be hepatotoxic. Many have been removed from the market. You can look at Table 7.1 to get a list of drugs that cause hepatotoxicity. These patients have to be monitored. We need to get baseline LFTs. We need to get them periodically thereafter. Again, an important role for nurses to make sure that these monitoring tests are taking place. Also, counseling. So when you're educating your patients, making sure they understand the signs and symptoms of hepatotoxicity. So jaundice, dark urine, light stools, nausea and vomiting, appetite loss, abdominal discomfort. These are things you're going to want to tell them that if they notice, they need to contact their prescriber or let you know. Moving on, renal toxicity. Drugs that cause liver injury, they could be acute or chronic. One example is amphotericin B. You will come across numerous drugs. As we're going through these lectures, we'll talk about a variety of drugs that cause renal toxicity. Neurotoxicity, this is just toxicity of the brain tissue. There are some agents that cause neurotoxicity. There are several chemotherapy agents, such as the beta alkaloids, that cause a wide range of neurotoxicity. Cardiotoxicity, this is just direct injury to the heart. Some anti-cancer drugs can cause this effect. One in particular is called doxorubicin. This drug is so toxic to the heart that there's a specific lifetime maximum dose that has to be monitored for this patient to make sure that they don't develop cardiotoxicity. Another form of cardiotoxicity are the QT drugs, or drugs that have the ability to prolong the QT interval of the EKG. When this is prolonged, patients can develop serious dysrhythmias, and specifically torsades de pointes, which can be deadly. More than 100 drugs are associated with QT prolongation. And so some patients are predisposed to QT prolongation, and so these drugs are most dangerous in those patients. For example, heart failure patients or patients with congenital syndromes of QT prolongation, those patients would be most at risk. Some drugs are carcinogenic. This means that they are able to cause cancer. It's difficult to ascertain sometimes since this effect can take years to manifest. But ironically, it's mostly the anti-cancer drugs that are associated with causing a secondary cancer after initial treatment. Finally, teratogenic drugs, and these are drugs that can cause birth defects. So teratogenesis, just so you know, less than 1% of all birth defects are caused by drugs. But this is, even though the number seems small, this is a really important issue. In pregnancy, about 2/3 of women take medications. And for your pregnant patients, you must be evaluating the risk-benefit for the mom and the baby when they receive a medication. There are lots of reasons why drugs can cross the placenta into the baby. There are a lot of physiologic changes in the woman's body, such as blood flow, renal filtration rate, hepatic metabolism, and so forth. Sometimes, changes in dose are needed to keep the mom safe, but also to keep the baby safe. The question with whether drugs cross the placenta is a really important question, and to what extent do they cross the placenta? And from a maternal standpoint, is there something that can be done to prevent that risk of teratogenesis to the baby? So you know, in 2009, the FDA launched a new program, the MedPrep program, which looks at basically labeling for medications with respect to pregnancy and lactation. So I'll talk about those in a moment. But so you know, sensitivity to teratogens changes throughout the stages of development. And so here you can see the effects of teratogens at various stages of development of the fetus. And you have your conception through week 2 phase, your embryonic phase, and then your fetal period. The embryonic period is weeks 3 through 8, and by far this is the most concerning of all stages. So caution is required. However, don't think this is the only place where caution is required. You really need to be cautious throughout the entire pregnancy for patients you're treating or patients you're administering medications to who are pregnant. But in that embryonic period, you see gross malformations as a result of ingested teratogens. So it's vital for clinicians to help patients minimize risk of teratogenesis during pregnancy and drug use. It's very important to evaluate all drugs patients are receiving and determine the risk for teratogenesis for pregnant patients. And it's not just for pregnant patients. So if you have a patient who is of childbearing age who could get pregnant while they're receiving a medication that's known to cause serious teratogenesis, it's very important to counsel that patient to use reliable birth control, especially because pregnancy is not always known until you're far into the embryonic stage. And by that point, if the patient's been taking that medication, the baby could have already suffered severe teratogenic effects. So some points: minimizing the use of drugs during pregnancy if possible, discontinuing drugs with high potential to cause teratogenesis, using safer alternatives when feasible, and then, as I mentioned, using reliable birth control. If you want to know whether a medication causes teratogenic problems, usually drug information resources have that information listed. And in fact, it's generally listed by the FDA pregnancy risk factors. And so you can see there's a scale A, B, C, D, and X. X considered the most dangerous, never to be used in patients who are pregnant or patients who want to become pregnant or patients who could be pregnant. And for those that latter group, they should be using effective birth control. So this is historically how the FDA assigned risk to medications with respect to pregnancy. Over the years, there's been concern about people thinking that these categories, it's just kind of like, oh, if the drug is A, B, or C, we're fine. But that's not really the case. You have to look at the individual patient and determine whether or not that drug in that patient is going to be safe. Just so you know, as of June of this year, it's kind of hot off the presses, these risk factors are being eliminated. It's going to take several years for this to be phased in, however, but ultimately, probably, I would say 5 or so years from now, we're going to see this information presented quite differently. So let me show you what that'll look like. So the new guidelines, drug labeling did change a bit, as I mentioned, so that first category, pregnancy, became pregnancy and labor and delivery. There's now a section for lactation, and then there's a new section that discusses reproductive risks of meds for both males and females. So not just pregnancy and lactation, but also reproductive risk. This is what the revised format will be. So no longer will you just have a category, A, B, C, D, or X. Now you'll have relevant information in the drug product guidelines. Again, you're not going to see this information anytime soon. It's going to be at least 3 or 4 years before this even starts to hit the presses or the drug information sources. But, several years from now when you start seeing it, you can think back to this lecture. In summary, or not in summary, but I guess before we get to our summary slides, one other thing I wanted to mention was drug therapy during breastfeeding. So drugs can be excreted in breast milk and they can affect the infant. So the question is, how can we decrease exposure? First of all, you need to know if it's safe or not. Can the drug or should the drug be given during breastfeeding? And again, this is information that you can look up in your drug information references. Is it excreted in the breast milk? To what degree is it excreted in the breast milk? Those are kind of the first questions. Secondly, things you can do. Take the drug immediately after breastfeeding. So, right after the patient has pumped, then take the medication and, avoid that drug if you're about to breastfeed again. Avoiding drugs that have long half-lives. So if you use drugs with short half-lives, you can kind of take advantage of the feeding pattern of the baby and alternate when you take those medications. Choosing drugs that tend to be excluded from the milk. So again, knowing whether the drug is excreted in the milk or not, and choosing alternatives that aren't excreted in the milk. And then, of course, avoiding drugs that are known to be hazardous. So not all ADRs progress to the level of a toxicity, but either way, how do we know that patients are experiencing ADRs from drugs they are receiving? And these are some standard questions that can help us determine whether the drug is to blame or whether there's some physiologic problem that's to blame. So, look through these questions and, in context, I think they make a lot of sense and can help us figure out whether it's the drug. And I think for you guys, the most important point is how do we minimize adverse effects? Because as a nurse, that's one of your responsibilities. So I guess a few important things you can do. Anticipate the ADRs that you would expect from medications you're giving to your patients. Obviously, balance the risks of adverse events against the risks of therapy. So understanding your individual patient and, if a drug is going to, if you have an elderly patient and the drug is on the Beers criteria list where you can expect that they're going to experience severe side effects, maybe we don't use that drug in that particular patient. Or maybe we reduce the dose and we individualize therapy. Providing education to patient on recognizing adverse effects and how to minimize adverse effects is also important. Finally, I want you guys to look in your textbook in Chapter 7. The last couple pages, there is some information about what the FDA requires around adverse effects. So we talked during our med safety lecture about reporting med errors, but you should also report adverse events or side effects, not necessarily those due to medication errors. The FDA MedWatch program collects these reports and analyzes them and looks for problems with drugs once they're on the market. And several drugs have been removed from the market after data from the MedWatch program has revealed a life-threatening toxicity. And I posted the link to the MedWatch reporting program in your med safety module. So other actions to reduce adverse events from certain medications with serious known side effects are listed in your book in pages 66 and 67. I want you guys to read this section, gain a better understanding of medication guides, box warnings, and the REMS program. The book provides a very nice overview of those.
So thank you for listening. If you have questions, please post them to the discussion board.